So the next session is the college lecture, and as has been customary for this year, we have a partnership with a sister college for each month, and this month our partnership is with the Sri Lankan Association for Geriatric Medicine, Association of Geriatric Medicine. I have the president of the Sri Lankan Association of Geriatric Medicine, Professor Sarath Lekambasam, as my co-chair. And sir, may I invite you to introduce the speaker and commence the session?
Thank you, Senaka. And I am most happy to introduce the speaker today, Dr. Varsha Dilhani Soissa, and she comes from our department really. So Varsha got her MBBS in 2005 from the Faculty of Medicine, University of Colombo, and she got her MD Medicine from the PGIM in 2012, and she was the top of the list. She was the first in the merit list. Varsha, once she got the board certification, she continued in the Ministry of Health for a short period as a resident physician teaching hospital Mahamudra, and also she was RP in teaching hospital Karapitia, and before some people twisted her hand to join a university system, and now she's in the university system now. So Varsha has a special interest in geriatric medicine, and particularly orthogeriatrics. So we thought that when this topic came up, she's the choice for this thing. She has a couple of publications and under her belt. So I would invite Varsha to make a presentation.
Thank you very much, sir, for those kind words of introduction. Good afternoon to you all. And first of all, I would like to thank the Ceylon College of Physicians and the Sri Lanka Association of Geriatric Medicine for the opportunity. Over the next half an hour, I will be speaking on the management of fragility fractures in old age in the perioperative setting from an orthogeriatric perspective. Let me start my talk with a common case scenario. And I'm sure that most of you all have seen this type of patients in your day-to-day practice. This is a lady in her late 70s who admitted to A&E department following a fall with painful left hip with difficulty in bearing weight. She had multiple comorbidities including diabetes, hypertension, ischemic heart disease and atrial fibrillation. She was on losartan, bisoprolol, metformin, glycoside, atorvastatin as well as warfarin. On admission, she was pale, dehydrated and disoriented. She was in fast AF with blood pressure of 100/80. Her initial investigation revealed hemoglobin of 7.2, raised urea and creatinine as well as sodium. Random blood sugar was 380. ECG revealed fast AF. INR was 2.5. X-ray hip showed fracture neck of the left femur. She underwent CT brain because she had been on warfarin, she had a fall and she was disoriented on admission. So CT brain showed small vessel disease. So she has been seen by the orthopedic surgeon and he made a referral to orthogeriatrician in order to optimize these patients' medical conditions for early surgery. So we have an old lady with multiple comorbidities who admitted following a fall, ended up with the hip fracture, right? Who need early attention or early intervention, but the clinical picture was complicated with multiple acute medical problems. Here, the orthogeriatricians come to the picture. So at the end of the lecture, I want you all to understand the role of the orthogeriatrician in the management of fragility fractures in elderly in the perioperative setting. Let me briefly tell you the fragility fracture burden in Sri Lanka. Falls and force-related injuries are common in elderly, especially those over the age of 70. They are the low-energy fractures that result from falling from the standing height or lower heights. Hip fractures being the most common in terms of morbidity and the cost. However, other sites like shoulder, the wrist, proximal femur, pelvis, ankle, as well as spine can be fractured in old, frail, osteoporotic individuals. So fragility fractures represent a global growing health problem. This is because the population ages at a faster rate than once thought. The Sri Lankan situation is not different from the global situation. According to WHO figures, the Sri Lankan population over the age of 65 is increasing and is expected to be tripled in the year 2050 compared to the figures in 2018. In keeping with that, the hip fracture prevalence is also expected to be tripled in the year 2050. As a result, the surgical procedures for fragility fractures are increasing steadily due to the multiple reasons. Because of their old age, comorbidity, frailty, they are susceptible to multiple post-surgical adverse side effects, the outcomes. So what is the goal in the management of these patients with fragility fractures? Goal is to make the surgical repair as safe as possible in timely manner, ideally within 24 to 48 hours. It has been shown that the early operative interventions improves the patient's overall outcome, including the morbidity, length of hospital stay, functional outcome, as well as the mortality. On the other hand, the unnecessary delays to the surgery result in many negative outcomes, including delirium, problems related to immobility, such as infections, thromboembolism, pressure sores, problem with nutrition, as well as mortality. Therefore, it is important that these patients are being managed by a multidisciplinary team to ensure the best quality of care with the aim to fast-track these patients for early surgery. Who are the members of the team? Orthopedic surgeon, anesthetist, more importantly, the orthogeriatrician, physiotherapist, occupational therapist, sometimes the social worker. Their aim is to optimize this patient's condition, importantly, the medical conditions, early so that undue delays to the surgery can be avoided. So, earlier surgery, lesser complication, shorter length of hospital stay with better functional outcome. Over the next 20 minutes, I will be highlighting the common medical issues an orthogeriatrician will encounter when dealing with these patients with fragility fractures in the perioperative setting, and the steps to be followed when optimizing these patients, the medical issues, the acute medical issues especially, to avoid unnecessary delays to the surgery. Here I have listed some common problems in his list in the perioperative setting. First of all, he should know what medical condition, chronic medical condition that the patient has. More importantly, he should know and he should detect promptly, identify what acute treatable medical condition the patient has developed with this insult that can probably delay the surgery. As you all can remember, recall my case scenario at the onset. That lady with multiple comorbidities admitted following a fall and sustained a fracture, and on admission she was disoriented, likely to be delirious, and she had, she was gone into fast AF, anemic, possibility of acute kidney injury, blood sugar was raised. So she had multiple acute medical conditions that need optimization prior to surgery. If we have not detected early, acted promptly, the surgery is likely to be delayed. Right? That is the role by the orthogeriatrician to optimize, try and identify these problems, optimize this patient to avoid unnecessary delays. What if my patient has been on blood thinning agent? When can this patient undergo surgery? Right. So at the same time, he should take precautions, try and prevent the common post-operative or perioperative complication that these patients likely to be developed during this setting, due to immobility, trauma, surgery, and so on. For example, thromboembolism, problem with feeding, sepsis, bladder bowel incontinence. And he should know what is my patient's pre-morbid functional status or frailty level and the pre-morbid cognitive level. Why it is important? At least certain percentage of these patients are in the latter part of their life, right? Despite our maximum medical management in the ward setup, certain percentage of patients will develop organ failure in this setting, and the cardiac arrest. In that case, in that circumstances, are we going to escalate their care to the ICU level? Are we going to intubate them or actively resuscitate them in the ICU level? Will they be benefited from them? And will these acute insult be reversible? Right? So these decisions, the ceiling of care and the resuscitation status and the DNR decisions need to be considered and put in place, ideally in preoperative setting, before the surgery. All right. So a few words about frailty. Frailty is a progressive age-related decline in physiological system that results in decreased reserves. It increases individuals' vulnerability to stressors and increases the risk of adverse health outcomes. It is an independent risk factor for major morbidity and increased mortality in 30 days as well as 12 months after surgery. There are many scores to measure the frailty. However, clinical frailty score is one of the most commonly used instruments in the emergency setting. So this is the clinical frailty scale. So there are 9 numbers. So 1 is a very fit individual who are leading very active lifestyle, and 9 is a terminally ill individual who are approaching the end of life. So management of frailty in perioperative setting, what we can do as orthogeriatrician to optimize their underlying chronic medical comorbidities, right? And more importantly, it is important for us to, as I mentioned before, to determine the ceiling of care and the resuscitation status, sometime to decide whether our patient actually will benefit from the surgery at this point. Right. Delirium again is common in elderly in the perioperative setting. Right? So it easily can be missed or misdiagnosed as depression. It's a clinical diagnosis. There are several assessment methods to diagnose delirium, and there are predisposing as well as precipitating factors for delirium. So these are some predisposing factors for delirium, and these are some precipitating factors for delirium. So even dehydration, hypoxia, even the urinary retention, constipation. For these minor trivial things, these elderly patients can be delirious. So the geriatrician need to identify delirium as well as the cause for the delirium and promptly act. So we have to ensure the adequate pain relief and should avoid routine pre-medication them with benzodiazepine. However, if they have been on long-term benzodiazepine, we should not avoid, stop it abruptly. See, it's better to go through their drug chart. So they may be on multiple drugs that we can withhold, avoid, remove unnecessary drugs. The most importantly, we have to fast track them for the surgery and make them mobilize as early as possible. Diabetes is common in elderly. Both hyperglycemia and hypoglycemia have serious consequences in this setting. It is important to review their diabetic medication and monitor their blood sugar levels in the perioperative setting. So if they are on oral hypoglycemic agent and the glycemic level is reasonably well controlled and they can eat and drink, we can just continue their medication and we can, we omit their usual medication on the day of surgery. And it is advisable to withhold metformin 48 hours prior to the surgery for those who are at risk of developing renal impairment to avoid possible lactic acidosis. However, if their blood sugar level rises about 12 millimole per liter, especially when they can't eat and drink as well, right, in the preoperative setting, it's better to go for insulin infusions. As well, if the patient has been on short-acting or combined insulin preparation, at the same time they can't eat and drink, it's better to consider the insulin infusion again. Right? The patient may be on long-acting insulin analog. They can be continued during the perioperative setting, but may need some dose adjustment. What is the glycemic target we should achieve in the perioperative setting? So target is between 110 to 180. It should not too low, it's not too high. It's between 110 to 180. It is important that we make a plan to withdraw these infusion as early as possible in the post-operative setting once the patient can eat and drink, because it's important to put them back on their usual medication, right? So we are not going to continue this when the long term, after the surgery, when they have started eating and drinking. So we can put them back after, put them back on their usual medication once they start eating and drinking after the surgery. Chronic kidney disease is common in older individuals and is associated with adverse surgical morbidity. It is important to establish the duration of CKD and their baseline renal function. So CKD can be associated with many metabolic abnormalities at during this setting, like the anemia, the electrolyte imbalances, and uremia. So we have to identify these metabolic derangements and take action to correct these abnormalities to the acceptable levels pre-operative setting. Patients who are patients with end-stage renal disease who are dialysis dependent, we should dialyze them within 24 hours preoperatively, ideally, to prevent pulmonary edema. Drugs excreted in kidney may need dose as well as administration interval adjustment in the perioperative setting. Hypotension, especially during anesthesia, is common, right? The patient with background chronic kidney disease or renal impairment, the hypotension is not good, right? It can reduce their renal blood flow, so they can go into acute kidney injury in the background of chronic kidney impairment. So it's important that we make the anesthetic aware that this patient has background chronic kidney disease, so that he can take actions to try and minimize hypotension during the anesthesia, especially during the induction, and avoid using nephrotoxic drugs. And it's also advisable to withhold ACE inhibitor and ARB in the perioperative setting in patients with background chronic kidney disease. Anemia on admission is very common in elderly with fragility fractures and is an independent predictor of poor outcome. Nearly 40% anemic on admission. And the post-op anemia prevalence is 80%. What is the target hemoglobin we should achieve in the pre-operative setting? It is 9 grams per deciliter in frail patients without background ischemic heart disease, but it should be 10 grams per deciliter with the patients with ischemic heart disease. So 10 grams per deciliter level we may have to go for in the patients even without ischemic heart disease, but they are having postural symptoms when they are mobilizing on early post-operative days. If they are not steady on their feet because of the postural symptoms, still we have to top up their hemoglobin to 10. Cardiovascular disease. Patients with history of ischemic heart disease are clearly at risk of perioperative adverse cardiac events. So they may not be having established coronary artery disease, but they may have multiple cardiovascular disease, cardiovascular risk factors like uncontrolled diabetes, chronic kidney disease, uncontrolled hypertension. We have to correct the risk factors to optimize these risk factors to prevent, minimize them developing adverse coronary event during this setting. Patient with suspected coronary artery disease should be discussed with the anesthetist. Except the patients, unless the patient is symptomatic, surgery should not be delayed to perform cardiac intervention or investigations. Those already on beta blockers should be continued their usual dose preoperatively, and the measures should be taken to optimize their hemoglobin to the targets prior to the surgery. Valvular heart disease. Cardiac murmurs are often present in old age, and this may be the first time that they've been diagnosed with a cardiac murmur. Most of the time, it is trivial mitral regurgitation or aortic sclerosis. However, notable proportion of patients can be, diagnosed with significant AF, aortic stenosis, for the first time. So, if it is the case, that can influence the type of anesthesia. We have to carefully balance their fluid in the perioperative setting because they can go into pulmonary edema. However, echocardiography should not delay the timing of operation unless it is readily available. Conduction defects, pacemakers, and implantable cardiac defibrillators. Conduction defects again common in 12-lead ECG in old age. Temporary pacing is indicated only if patient has complete heart block or they are having history of syncope related to trifascicular heart block. Preoperative pacemaker check is not required routinely unless you have concern with this malfunction or it has not been checked within last 12 months. It's important to understand the reason for the device and whether your patient is pacemaker dependent or not. External pacing equipment and defibrillator facilities must be available during the surgery. The surgical diathermy can interfere with the electrical interference. It can have an electrical interference with the function of the pacemakers and the ICD. It is advisable to minimize the usage of electrical diathermy in patients with pacemakers and ICD. ICD can be turned on to monitor only mode if a technician is available or turned off by placing a magnet. Any sustained VT or VF intraoperatively should be managed with external defibrillation. Post-operatively, the magnet should be removed and the patient should be monitored till the device has been checked. Atrial fibrillation. Patient may have new AF, persistent AF or paroxysmal atrial fibrillation. Patient with chronic AF, with control, with good control, with the controlled ventricular rate, with usual rate controlling drugs preoperatively, no issue, that we just need to continue their usual medication on the day of surgery. Patient with FAP, we can try amiodarone, flecainide or beta blockers to try and maintain them in the sinus rhythm in the perioperative setting. Problem is with fast AF. So fast AF may be due to multiple reasons in the perioperative setting. This may be due to pain, infection, anemia, adverse cardiac event, and so on. We have to identify and correct the underlying cause for the fast AF. Even after correcting the underlying cause for the fast AF, the patient remains the fast AF, then we have to take actions to correct it. Right? With what agent? Right? If you are going to try edoxin, it will take 24 hours for the onset. Right? Beta blockers for the first time in the perioperative setting is not advisable because of concern with hypotension. So it's the most effective method for rapid rate control is with intravenous amiodarone bolus followed by infusion. So the management of antiplatelet during the perioperative setting. Right? So majority of these patients, significant proportion of these patients likely to be on at least single antiplatelet therapy. Right? So the anesthetist as well as the orthogeriatrician has to balance the four main risks. Surgical bleeding while continuing these drugs, rare but serious complication of spinal anesthesia, vertebral canal hematoma, and problem associated with abrupt cessation of these medication and delays to the surgery due to this medication. However, delay for urgent surgery is not recommended even though patient has been on dual antiplatelet therapy. If it is urgent, we have to go ahead with the surgery. If the patient has been on monotherapy, aspirin or clopidogrel, it should not delay the surgery and it is not a contraindication for spinal anesthesia. General anesthesia should be considered for those patients who are taking dual antiplatelet therapy. Anticoagulation. Interruption of anticoagulation increases the risk of thromboembolism. On the other hand, the continuation of it raises the risk of bleeding during the procedure. So at least for those who are at risk of thrombosis, high risk of thrombosis, like atrial fibrillation with high Chatzwell scope, the recent VTE, patient with cardiac stenting or prosthetic heart valve, we have to limit the period without anticoagulation to the shortest possible interval. Patient on warfarin, surgery under general anesthesia is recommended when the INR is less than 2. Spinal anesthesia and surgery are considered safe when the INR is less than 1.5. Bridging anticoagulation. Who need bridging? So bridging is, we are going to replace their usual long-acting oral anticoagulation with short-acting injectable anticoagulation in the period where they are going to off their oral anticoagulation. So bridging is recommended for high-risk patients on warfarin. So AF with high Chatzwell scope, recent VTE, coronary stenting or prosthetic heart valve. So bridging can be done with low molecular weight heparin. If you have started bridging with low molecular weight heparin, in the preoperative setting, that's before the surgery, we have to stop it 24 hours prior to the surgery. So the patient with renal impairment, the bridging is recommended with unfractionated heparin. If you have started unfractionated heparin before the surgery, it's recommended to stop it 2 to 4 hours prior to surgery. Bridging can be used preoperative setting, postoperative setting, both pre and both postoperative setting, depending on the underlying condition and delay to the surgery. If the patient has been on direct oral anticoagulants or DOACs, it should be stopped 24 hours prior to the surgery. At the same time, the physician or the geriatricians take precautions to try and minimize their patients developing the common perioperative complications like thromboembolism. So it is recommended that daily prophylactic dose of low molecular weight heparin or fondaparinux for all hospitalized patients with fragility practice unless contraindicated. So you can consider VT prophylaxis preoperatively if the surgery is going to be delayed for more than 24 hours. So if you have started prophylactic dose of low molecular weight heparin, it has to be stopped 12 hours prior to surgery. If you have started fondaparinux for the prophylaxis, it has to be stopped 24 hours before the surgery. When now we're going to recommence or commence the prophylaxis after the surgery. It is recommended to commence it 6 to 12 hours after the surgery and continue it for at least 1 month to people with fragility fractures of the pelvis, hip, or proximal femur. Intermittent pneumatic compression is indicated for those who have contraindication to pharmacological prophylaxis. And we have to anticipate and treat the infection, hypoxia, carefully balance the fluid, and so on. So a few words about sealing of care. So many of these patients with fragility fractures have significant frailty and quarter of them are in their last year of life. So organ failure as a result of end-stage chronic disease is usually reversible. And under these circumstances, organ support in an intensive care unit is unlikely to be effective. As well the cardiopulmonary resuscitation. So these decisions need to be set up and put into place before the surgery. So in summary, perioperative management of patients with fragility fractures requires skill, time, and effort. It is best achieved through multidisciplinary teamwork with a key role to be played by the orthogeriatrician. Perioperative management should be driven by the goal of optimizing the patient for early surgery, ideally within 24 to 48 hours. Prompt detection and treatment of early postoperative complications improve the patient's overall functional recovery. Thank you.
Thank you, Arsha, for that comprehensive overview. Just one question. The pain management is one of the key components of the postoperative and preoperative and postoperative care. And that is known to reduce the incidence of delirium as well. As you said in one of the slides, pain management. I think that also we need to address in the management of these patients.
Yes, sir. So it is said that the pain management, so ideally with paracetamol, IV paracetamol, which is not available readily in the government sectors, and the injectable opioids, the self-controlled injectable opioids. If it's both is not working, then we can go for the local nerve block. But the NSAIDs in the perioperative setting is contraindicated in elderly.
And I think the world over people have shown that the people who did not have surgery done within, let's say, 24 hours and 48 hours, and they had a poor clinical outcome immediately after, and also, let's say, 1 year down the line. The couple of publications that we have done here in Sri Lanka also showed that only nearly about 50% of patients are operated, actually as bad as 50% patients are not operated for various reasons, actually. So there is something that we should think about, really.
Yes, sir, that's true. In fact, it's sometimes quite a challenge to convince family members, particularly if the patient is very elderly, and to convince them that if you don't fix this, then you are looking at a very poor outcome. And then they come back often late. Yes. And by the time there are a lot of other medical complications which have taken place and there is no hope. So it's I don't know what we can do about it, how we can educate the public more. of the importance, because if you have a fracture and you don't fix it, basically that is it. The complications are inevitable. So I think that message is very important.
Very important,
isn't it?
yeah.
Yes. And it's often due to beliefs that the patient is not very mobile and can go on without being able to bear weight. But then eventually something will happen within the next 3 months, and it's very unlikely that you'll survive for more than a couple of months. Isn't it? Yes. It's a very important message, I think.
Especially if they don't, these acute treatable condition, if we missed it early, it's like a cascade, one after the other.
Absolutely.
Absolutely, yes. That's a very important message. Any questions from, there's nothing from the audience, but shall we?
Close, yeah.
So thank you very much. That was a really interesting and very comprehensive talk.
you,
I think
sir.
it should be viewed by any physician who is looking after patients, especially we all come across elderly patients, whatever setting we are in. And the messages were very, very clear and very, very impressive and
Thank you,
important.
sir.
Thank you very much.
Thank you, sir.
So I think there is a certificate of appreciation